Good morning. Thank you so much for joining us. My name is Rachel Krug, and I'm the CEO of Virtual Field. Virtual Field is an exceptional eye exam experience with visual field, color vision, and pupillometry exams in this portable, patient-friendly headset. I am joined today by Dr. Arpine Barsegian, and she is here to talk to us about the types of glaucoma. I am going to turn it over to her. If you have questions at any point during the presentation, feel free to put them in the chat and we will respond. Take it away.
Thank you so much, Rachel. My name is Arpine Barsegian. I am a general ophthalmologist and glaucoma specialist practicing in Orange County, California. Thank you so much for the opportunity to speak today. I'm actually originally from New York City. I completed medical school and residency at State University of New York, SUNY Downstate Medical Center in Brooklyn. And then I moved over to the West Coast where I completed a cornea and external disease fellowship at Doheny Eye Institute, and then a glaucoma fellowship at UCLA. I will be covering an overview of different types of glaucoma, and I'm happy to answer any questions at all. I'll also include my contact information at the end of the slides in case questions come up after. Let's start with pseudoexfoliation glaucoma. So pseudoexfoliation syndrome is a systemic condition characterized by the deposition of white dandruff-like material called pseudoexfoliation material within the anterior segment of the eye and various organs of the body, such as the heart, the lungs, and the kidneys. The deposition of this material within the trabecular meshwork results in increased aqueous outflow obstruction and elevated IOP. Risk factors include older age, genetic prevalence, and Scandinavian and Mediterranean descent. So every Eastern European, Armenian, Greek, or Scandinavian patient who walks into my office has pseudoexfoliation until proven otherwise. In fact, pseudoexfoliation glaucoma is the most common form of secondary open-angle glaucoma. Not all patients with pseudoexfoliation will develop glaucoma, and it's difficult to discern which patients are more susceptible. However, about 20% of patients with newly diagnosed pseudoexfoliation will have either elevated IOP or glaucoma. Importantly, sometimes these patients are misdiagnosed as POAG if the pseudoexfoliative material is overlooked, but it is important to distinguish between these two conditions because pseudoexfoliation patients should be followed more closely as their disease tends to progress more rapidly. The classic finding on examination is this white pseudoexfoliative material, this white dandruff-like material right here, which we would see on the pupillary margin and on the anterior lens capsule with a clear intermediate zone. The clear zone is due to rubbing off by the iris. About 20% of these are actually missed on undilated eyes, so it's very important to dilate these eyes. Pseudoexfoliation material can also be seen on the conjunctiva, the corneal endothelium, the trabecular meshwork, and the zonules and the ciliary processes. In pseudophakic and aphakic eyes, one can even see it on the intraocular lens and vitreous phase, respectively. Peripupillary TIDs and porpupillary dilation are commonly noted. Gonioscopy will show an open angle with the presence of Sempelesi's line, which is an anterior line, which is a pigmented line found anterior to Schwalbe's line, as well as this uneven pigmentation of the trabecular meshwork. Patients with pseudoexfoliation will often ask me, what are the chances that I will get glaucoma? So I like to keep these stats handy. A 2002 10-year prospective study from Sweden analyzed the rates of conversion from non-glaucomatous unilateral to bilateral pseudoexfoliation and to glaucoma. Conversion from unilateral to bilateral pseudoexfoliation was about 33% in 5 years and 40% in 10 years. And 33% of eyes did develop glaucoma within 10 years. Excuse me. The early manifest glaucoma trial found that 55% of patients with pseudoexfoliation did develop glaucoma after a mean period of 8.7 years. Risk factors for conversion include the presence of pseudoexfoliation material, both within ocular tissues and bilaterally, poor pupillary dilation, ocular hypertension, and the presence of pigment in the angle itself. In fact, it's actually the amount of pigment present in the angle that correlates more closely with the severity and development of glaucoma than does the amount of pseudoexfoliation material noted on the lens capsule. These patients have high IOP fluctuations. In fact, it's much more challenging to treat these patients than patients with POAG because although initially they respond well to an initial IOP lowering agent, because of the 24-hour IOP characteristics and IOP fluctuations, it's really difficult to reach our predetermined target pressure. So often we have to add adjunctive therapy with additional medications or laser therapy. These patients also require filtering surgery more often than patients with POAG due to medically uncontrolled glaucoma. They do quite well initially with SLT because of the increased pigmentation of the trabecular meshwork. They do absorb a lot of energy during SLT. However, there is about a 50% failure rate after 5 years. Cataract surgery in the setting of pseudoexfoliation is more challenging. There is an increased risk of complications. So we do like earlier rather than later cataract surgery in these patients. The less dense the cataract, the easier it will be to perform cataract surgery. Lastly, why am I even mentioning an LPI since this is classically an open angle glaucoma? And this is why it's important to perform serial gonioscopies in these patients. Yes, originally this does start out as an open angle glaucoma, but over time, as pseudoexfoliation material is deposited in the lens zonules, the zonules weaken, the lens moves forward, and the angle actually narrows. And in those patients, LPIs can be quite helpful in controlling glaucoma. Overall, about half of patients with pseudoexfoliation will develop glaucoma. Therefore, annual assessment is critical. Patients who do develop pseudoexfoliation should be followed more closely than patients with POAG and treated more aggressively because they have poor response to medications and an increased need for surgery. Unfortunately, they also have a worse prognosis than patients with POAG. Pigment dispersion syndrome and pigmentary glaucoma represent a spectrum of the same disease characterized by excessive pigment liberation throughout the anterior segment of the eye. The classic triad includes mid-peripheral TIDs, a Krukenberg spindle, which is essentially pigment present on the posterior surface of the central cornea, as well as dense homogeneous pigmentation of the trabecular meshwork. Excessive pigment liberation can temporarily overwhelm the trabecular meshwork and lead to elevated IOP as seen in pigment dispersion syndrome, or it can lead to optic nerve changes and associated visual field loss as seen in pigmentary glaucoma. Pigment is released from the iris pigment epithelium due to rubbing off of the posterior iris onto the anterior lens zonules. Importantly, this is commonly seen in myopic males between the ages of 30 to 40. The exact mechanism by which this occurs is the presence of a concave iris contour, which leads to rubbing of the posterior iris against the anterior lens zonules during physiological pupil dilation, leading to release of pigment granules, temporarily overwhelming the trabecular meshwork, and elevated IOP. Importantly, the amount of pigment seen at the slit lamp does not correlate with the risk of developing glaucoma, but over time, due to pathological changes in the trabecular endothelial cells and collagen beams, the aqueous resistance or resistance to aqueous humor outflow does become permanent, and patients develop elevated IOP and secondary glaucoma. Really, UBM demonstrates this best. So on the top right here, we actually have the UBM of a normal eye, and the black arrow here points to scleral spur, which is an important landmark to assess morphological relationships among anterior segment structures. Here on the bottom right, we actually have the UBM of an eye with pigment dispersion syndrome, and note the incredibly wide iridolenticular contact and the concave iris contour. Risk factors include male gender, Caucasian descent, myopia, family history, posterior iris insertion, and concave iris contour. Typically, this is seen in Caucasian men between the ages of 30 to 40 who have underlying myopia and a family history of this condition. Examination findings will show the presence of pigment on the corneal endothelium centrally. This is referred to as a Krukenberg spindle. It is in the shape of a spindle, denser centrally, and tapering out in the periphery. Importantly, this is not visually significant, no matter how dense the pigment is. Gonioscopy should be performed prior to dilation. One will note an open angle with concave iris contour and dense homogeneous pigmentation of the trabecular meshwork. TIDs are typically present in the mid-periphery, mainly because this is where there's maximal contact between the posterior iris and anterior lens zonules. They are in a spoke wheel configuration, most commonly inferiorly and inferior nasally. Pigment may also be seen on the anterior lens capsule, lens zonules, and posterior lens capsule. Zonular pigment is best visualized after dilation, with the patient looking up to bring the inferior zonules into view. Pigment may also be noted at the zonular attachment of the posterior capsule of the lens. This is referred to as a Chier stripe. When pigment is present at the lens equator, it's referred to as a Zettmeyer ring. Pilocarpine has actually been shown to eliminate iris concavity and prevent exercise-induced IOP elevation in these patients. However, it also causes additional myopia, accommodative spasms, and increases the risk of retinal detachment. So a careful retinal exam should be performed in these patients. Excuse me, I'm so sorry. Much better. A careful retinal exam should be performed in these patients prior to initiation of miotics, because they actually have an increased risk of retinal detachments, and about 20% of these patients have lattice degeneration. For these reasons, we have largely replaced miotics with prostaglandin analogs and aqueous suppressants. Prostaglandin analogs are preferred to aqueous suppressants because aqueous suppressants actually slow down the clearance of pigment from the anterior chamber. In regards to laser iridotomy, so basically, because this is due to a pressure differential across the iris from the anterior to posterior chambers, there was a theory that an LPI can potentially eliminate the underlying mechanism of disease. Unfortunately, LPIs, even though they reduce iridolenticular contact and iris concavity, they don't work after the age of 40. They only work for short periods of time, and they don't prevent exercise-induced IOP elevation. To date, there are really no high-quality prospective studies supporting the use of LPI in these patients. SLT is quite helpful in these patients because of the dense homogeneous pigmentation of the trabecular meshwork. They absorb a lot of energy. So I recommend using lower energy settings to prevent trabecular damage, PAS formation, and permanent elevation of IOP. When it comes to trabeculectomy, they do quite well with filtering surgery in general. However, we have to remember that these are myopic young patients typically, and so they are prone to hypotony postoperatively. So we do take extra precautions during surgery to try to prevent hypotony. Lastly, I would be very careful with steroid use in these patients because they are very, very, very responsive to topical steroids. So treating them, for example, with like steroids for dry eye, I would be very careful because their IOP can rise dramatically and quickly. These patients, in general, can have high IOP fluctuations despite treatment compliance because pupillary dilation or moderate exercise can cause release of pigment and elevated IOP. Thankfully, blindness is quite rare. There is about a 10% risk of converting to glaucoma at 5 years and 15% at 15 years. Importantly, this disease has actually been shown to burn itself out over time. So trabecular meshwork, pigmentation, mid-peripheral TIDs, and even IOP has been shown to normalize over time, suggesting return of normal trabecular meshwork function. Some patients even present with low IOP after prolonged periods of elevated IOP, and this is believed to be due to the pigment release process burning itself out over time due to an unexplained reduction in posterior iris friction and improvement in aqueous outflow facility. Angular recession glaucoma is a secondary opening of glaucoma that's associated with a history of ocular trauma. Recession of the angle, shown by widening of the ciliary body band on gonioscopy, is classically seen in these patients. I will discuss this in further slides. Angle recession is very strongly associated with a history of traumatic hyphema, with studies reporting a 60 to 100% incidence of angle recession in patients who have a history of traumatic hyphema. Initially, IOP elevation is due to anterior segment inflammation and the presence of a hyphema, which leads to elevated IOP, which then normalizes after about 4 to 6 weeks of treatment. Later on, about 10% of cases with at least 180 degrees of angle recession will develop glaucoma. There are 2 peak incidences of glaucoma development after the initial trauma, 3 years after and 10 years after. The mechanism of recession is as follows. Blunt trauma forces aqueous humor posteriorly and laterally against the iris at angle, which puts traction on the iris root and leads to a tear between the longitudinal and circular muscles of the ciliary body. Injury to the trabecular meshwork leads to increased aqueous outflow resistance. Widening of the ciliary body band is classically seen on gonioscopy. This, in the setting of elevated IOP and optic nerve damage, leads to a diagnosis of angle recession glaucoma. Importantly, some patients actually have a broad ciliary body band at baseline, so it's important to compare any suspected areas of widening of the ciliary body band to the contralateral eye to avoid mistaking physiologic widening as pathologic, and also to avoid mistaking 360-degree recession as normal. Any patient who's had a history of ocular trauma, no matter how remote, should have a gonioscopy to assess for widening of the ciliary body band and angle recession. A Vossius ring is a ring of pigment that is typically seen on the anterior lens capsule resulting from blunt trauma. It may result in a complete or incomplete ring of pigment. A cyclodialysis cleft should not be confused with angle recession. So a cyclodialysis cleft is actually an anatomical cleavage between the scleral spur and the ciliary body, resulting in early hypotony. And one would see on gonioscopy a white tissue, which is sclera, between pigmented trabecular meshwork and ciliary body. Here on the right, we have an example of a gonioscopy finding of cyclodialysis cleft, where the red arrow is actually pointing to that white scleral spur. On the left, for comparison's sake, we have an image of widening of the ciliary body band, typically seen in angle recession. UBM, once again, does demonstrate this best. So on the far left, we have the UBM of a normal eye. Once again, that black arrow points to scleral spur. Here in the middle, we have an example of angle recession, and we see that blunt trauma has put a tear in the ciliary body face, but the iris is still attached to the scleral spur, and there's no direct communication between the anterior chamber and the supraciliary space. On the far right, we have an example of a cyclodialysis cleft where we see the ciliary body has been avulsed from scleral spur, and now there's actually direct communication between the anterior chamber and the supraciliary space, which is noted by an asterisk. Treatment for these patients is very similar to POAG, save for a few exceptions. We avoid pilocarpine because that can actually worsen angle recession. And trabeculectomy in general is quite successful in these patients when necessary. Unfortunately, SLT has no role in treatment for these patients. So I will be talking about uveitic glaucoma from the point of view of basically glaucoma that develops in the setting of uveitis. So uveitic glaucoma is a term that describes glaucoma that results either directly or indirectly from uveitis. It affects about 20% of patients with uveitis, and it's most commonly seen with anterior and chronic forms of uveitis. It has open or closed angle mechanisms. It can also be due to steroid-induced glaucoma, which I'll discuss in further slides. It can also be acute or chronic in nature. Acutely, IOP elevation is due to the trabecular meshwork outflow being blocked by either inflammatory cells or fibrin, by serous effusion, serous RD or uveal effusion leading to acute angle closure, or by trabeculitis, which is a swelling of the trabecular endothelial cells. Over time, with more episodes of uveitis, fibroblastic infiltration and scar tissue can develop in the angle that slowly obstructs the angle. In the chronic setting, trabecular meshwork outflow is decreased by scarring and obliteration of the trabecular meshwork, growth of a fibrovascular membrane, or acute angle closure. Treatment of this is two-pronged. First, we must understand the etiology of uveitis and treat it appropriately. And secondarily, of course, we have to treat our glaucoma, making sure to assess for steroid-induced ocular hypertension. How does steroid response play into this? So it's important to remember that in general, an IOP elevation in response to steroids takes weeks to develop and then normalizes after 1 to 4 weeks of steroid discontinuation. The confusion arises when pressure goes up a few days after starting steroids for uveitis, and I can explain why. Generally, I'm talking about bread and butter uveitis because there are forms of uveitis that are associated with high IOP. I'm not discussing that. I mean bread and butter uveitis. In bread and butter uveitis, inflammation causes the ciliary body to shut down and the pressure is quite low. On presentation, as we give patients steroids, the inflammation calms down, the ciliary body wakes up and starts to produce a lot of aqueous humor, overwhelming the trabecular meshwork, and the IOP goes up. This is not a steroid response, and the answer to this is not to stop or taper the steroids. The answer is simply to treat the ocular inflammation with steroids, as well as to treat the ocular hypertension separately. The exact mechanism by which steroids cause elevation of IOP is unknown. In general, we believe that it's due to a reduction in aqueous outflow facility. One such theory is that steroids actually suppress the phagocytosis of the trabecular endothelium, leading to accumulation of aqueous debris and subsequent elevation of intraocular pressure due to a decrease in aqueous outflow facility. Treatment depends on clinical presentation, but it's aimed at controlling ocular hypertension, decreasing ocular inflammation, and diagnosing and treating systemic disease. The major objectives are to provide our patients with symptomatic relief, to protect the optic nerve from the damaging effects of persistent or acutely elevated IOP, as well as to prevent sneaky eye formation, to prevent acute angle closure, and further need for surgical therapy. In the chronic setting, of course, or long-term setting, we want to avoid future attacks of uveitis. Medical therapy is used first, and only in cases refractory to medical therapy, surgical therapy even considered. Importantly, in the setting of minimal or no optic nerve damage, a target IOP in the low 20s may be quite adequate, especially assuming average corneal thickness. So in general, we start treatment for uveitis with cycloplegics and corticosteroids. Cycloplegics are critical to prevent sneaky eye formation. Eventually, patients may need to be placed on steroid-sparing agents to control their uveitis. Ocular hypertension is controlled initially by aqueous suppressants like beta blockers and alpha-2 agonists. A couple of caveats about this. Number one, the IOP response in an inflamed eye is pretty unpredictable. So for example, beta blockers cause an IOP reduction of 30% or so in most patients. It may be more so or less so in an inflamed eye. Carbonic anhydrase inhibitors can actually inhibit corneal endothelial carbonic anhydrase and should be used with caution in patients who have corneal edema. Miotics should be avoided as they can cause further breakdown of the blood aqueous barrier. Prostaglandin analogs in general have been shown in certain cases, rarely, to cause increased inflammation in these eyes, which is why we usually start treatment with aqueous suppressants first. However, If patients have very high IOP or high IOP despite max aqueous suppressant use, and I'm picking between a prostaglandin analog or surgery, I'm going to try a prostaglandin analog first. I will avoid a prostaglandin analog if the eye is aphakic, if they have active CME, or a history of HSV epithelial keratitis. With that said, if they have a history of HSV stromal keratitis or uveitis, we can use prostaglandin analogs. I have confirmed that with a uveitis specialist who I really trust. It is also important to correctly diagnose pupillary block in these patients and perform an LPI if necessary. Sometimes in an inflamed eye, iridotomies don't stay patent, so a surgical iridectomy may be necessary. Surgery is reserved for refractory cases unresponsive to maximal medical therapy. These are usually patients who either have severe optic nerve damage or they're at risk of severe optic nerve damage, as well as for cases of acute angle closure. We avoid surgery during active inflammation because inflammation does reduce the rate of surgical success. Our surgical treatment of choice is implantation of an aqueous drainage implant or a glaucoma drainage implant. Such as an Ahmed valve. We do like to co-manage these cases with a uveitis specialist. They are our allies in these cases. Importantly, in regards to SLT, SLT has no role in the treatment of uveitic glaucoma, but can be used in the treatment of steroid-induced glaucoma. Thank you so much again for the opportunity to speak today. Here is my contact information, and please feel free to reach out if you have any questions.
Thank you so much for your time, and thank you everybody for attending. We really appreciate it, and we will see you next time.